We go through a pretty intensive pre-surgical evaluation for patients with essential tremor. Number one, they have to have failed medications. So at least propranolol or primidone. The tremor has to be disabling enough. It has to be interfering with their overall quality of life. So we don't consider treatment for anybody who has just a minor tremor, because every operation will have side effects. They always tend to be mild, and in most of the time they're temporary.
Now, some people come in and they already have their mind made up. They want focused ultrasound, and even if I think that deep brain stimulation might be better for them, they want focused ultrasound. And the same with deep brain stimulation. Some people like the fact that it is something that can be changed over time, that it can be manipulated and that kind of stuff.
You have to make the patient understand which are the pros, which are the cons, which is the benefit that you are going to provide to the patient, and which are the potential complications. That is essential.
This pulse generator is connected to the electrodes and then inserted under your skin. So it's not very big. It sort of sits under your clavicle like that, and then we program that essentially through Bluetooth. When a patient comes in, I evaluate the patient, look at the extent of their tremor, and then really give them the whole picture. What is the whole spate of potential treatments for them? But if you have very severe bilateral tremor and it's expected to get worse, then a lot of times I think that deep brain stimulation is probably the best way to go. It gives us the ability to change the stimulation intensity over time. We know right off the bat we're going to be able to reduce the tremor on both sides. The other thing is whether they have a lot of head tremor. Bilateral treatment does reduce head tremor better than unilateral treatment. So you could actually change the parameters of deep brain stimulation to get a better impact on head tremor, voice tremor, that kind of stuff.
En algunos sitios es tendencia de pensar que la estimulación cerebral profunda es para jóvenes y los ultrasonidos para personas mayores. Yo en eso no estoy de acuerdo. Depende un poco del paciente, de la enfermedad.
Initially, when we first started doing focused ultrasound, I reserved it for elderly people who are too old to have DBS. My cutoff for DBS used to be 65. When I turned 65, I thought maybe we should push it up to 70. If I hit 70, maybe I'll push it a little higher. But the thing is that older brains and older people, they have more atrophy. Their blood vessels are more rigid. The risk of hemorrhage and complications from deep brain stimulation goes up significantly.
There is no age limitation for focused ultrasound. In the end, it's a matter of frailty. If the patient is too fragile to tolerate the procedure itself, being 2 hours in an MRI without moving, etc., or if the patient has gait instability, which can impair after the treatment because of the lesion, can impair and maybe not resolve completely if it's pre-existent, those patients might not be suitable candidates. Another limitation to undergo focused ultrasound is skull characteristics. We know that some people have some skull characteristics, the density of the skull mainly, but also the size of the skull, that could prevent ultrasound energy to penetrate into the brain. And if the ultrasound energy is not able to get into the brain, then you cannot do the lesion.
It's been a great advance in terms of patients who either don't like the idea of surgery, for patients that really are interested in sort of a one and done kind of treatment that they don't need to have a lot of follow-up. You can do bilateral lesions with focused ultrasound, but that's a staged lesion. If you're going to do both sides of the brain with focused ultrasound, you do one lesion and then you wait 9 to 12 months before you do the other lesion.
We get good and very substantial tremor control in around 80% of people. In about 20% of people, 20, sometimes 25%, as you follow people along, you can see recurrence of tremor. It's always better. I've never seen it go back to where it was, but it can come back. So The beauty of focused ultrasound, though, is that if it does come back, you can consider retreatment. It's evolving now because now with experience and good results, I can offer it to younger people with even less severe and horrible tremor. If it's interfering with their daily function and their overall quality of life. But I tell patients, this is still brain surgery. It's no touch brain surgery, but it's brain surgery. And they don't really understand that because they come in, a few hours later, they even go home. They have no tremor. They say, this is marvelous. And then they say, well, wait a sec, why am I off balance? They didn't do anything to me, but we did. I've been doing neurosurgery for a long time, and it's remarkable what has changed from 40 years ago to what is done now. And there's more room to explore different illnesses with deep brain stimulation, and there's more room to explore it with focused ultrasound.
I think my responsibility as a doctor is to be aware of all the tools that I have to offer to improve our patients' quality of life. We have to keep pushing and developing new tools. There's still a lot of things to do.